Hello, my name is Dr. Bryan Rade, and this is a presentation on low dose immunotherapy in the treatment of Lyme and co-infections. This is a presentation that I delivered at a Lyme disease conference in May of 2016 in Warren, New Jersey, and the audience that I was speaking to was largely comprised of clinicians, mostly naturopathic doctors and medical doctors. So you'll notice that the presentation assumes a certain working knowledge of the clinical presentation and pathophysiology of Lyme disease and co-infections. I have no financial interest in low-dose immunotherapy or any other topic discussed within this presentation. Given that my target audience for this presentation was clinicians, the main objective for the presentation was to go over some case studies to demonstrate how low-dose immunotherapy can be used in clinical practice. This is not a training seminar or training lecture in how to use low-dose immunotherapy. As we'll discuss in one of the last slides, I'll go over how you can learn to use low-dose immunotherapy in your own practice should you choose to do so. However, I will still go into some things like the history and composition and administration and so on and so forth of how LDI is done. But the main objective is to show how low-dose immunotherapy can apply to a wide range of different patient presentations when you're dealing with either chronic Lyme or some type of a co-infection. We'll also discuss during one slide how low-dose immunotherapy can be used for a number of different microorganism issues. It's not just limited to Lyme and co-infections. A brief note on who I am. As the title slide indicated, I'm a naturopathic doctor. I have a practice just outside of Halifax, Nova Scotia. I did my naturopathic training at the Canadian College of Naturopathic Medicine in Toronto, Ontario. My practice is comprised of approximately 80 to 90% of treating chronic infections, chronic pain, integrative cancer therapy, autism spectrum disorder, neurological disorders like MS and Parkinson's, and really anything that's treatment resistant or chronic in nature. I use a lot of intravenous therapy in my practice, including intravenous laser therapy, ozone therapy, and all the usual therapies that other integrative practitioners use, such as Myers cocktails and intravenous ATP, curcumin, alpha lipoic acid, phosphatidylcholine, chelation, etc. I also work with a lot of injection therapies. I use ozone therapy, prolotherapy, platelet-rich plasma therapy, neural prolotherapy, and neural therapy. And I also use a great deal of herbal treatments in my practice. I do something called endobiogenic medicine, in which I've completed a 2-year fellowship. It's essentially an in-depth look at diagnosing and treating endocrine issues and autonomic nervous system issues. We use pulsed electromagnetic field therapy, bioresonance therapy, homeopathy. We do methylation cycle testing and treatment. We use contact regulation thermography assessments, and we use a number of other assessments and treatments too. One thing that I've learned from treating patients who are suffering from chronic illnesses, it's rarely a one-size-fits-all approach that will help. So we have to have a wide range of different tools so we can assess and treat patients effectively. The first case study is an example of how low-dose immunotherapy can be part of an initial treatment protocol with a patient. So a patient who is presenting to your practice with clinical signs and symptoms of a chronic infection or with a lab confirmation that a chronic infection is afoot, and low-dose immunotherapy can be applied sort of right out of the gate in a case like that. This patient at the time of initial presentation was a 51-year-old female. She was presenting with fairly classic symptoms of a chronic infection like Lyme disease. The only thing that didn't really fit was the dyspepsia, although some chronic Lyme patients, of course, or chronic infection patients, of course, have dyspepsia. She'd been suffering from these symptoms for approximately 15 years, but the symptoms had become markedly worse in the past 3 years. She tried Cymbalta in the past, and it really flared her symptoms, so she discontinued it. She came in on a couple of analgesics. She was taking a PPI to help with the side effects of the analgesics, and she had self-prescribed some vitamins and minerals, holy basil, and probiotics, and none of those things seemed to be making a difference. The analgesics would help acutely with the pain, but the pain would shortly come back fairly shortly thereafter, and it was not addressing the cause of what was driving her symptoms. So I saw her for the first time in January of 2016, and I recommended that the patient start with some antimicrobial herbs, so a tincture of things like teasel or Uncaria tomentosa or Japanese knotweed, Artemisia, etc. I also put her on some liver support, some adrenal support, which was a combination of adaptogenic herbs and adrenal gland extract. And I also put her on a modified form of the GAPS diet, which in my practice is essentially no grains, no starchy vegetables, no dairy products with the exception of butter, and no refined sugar. So meaning that things like honey and maple syrup and stevia and things like that are fine, but no cane sugar, high fructose corn syrup, etc. So she started that protocol on January 29th, and on January 30th, i.e. the next day, she took her very first dose of LDI. Her first dose of LDI, as indicated here on the top bullet point, was a Lyme 20C dosage. So I'm just going to take a minute to explain what that means exactly. So the Lyme LDI formula is a combination of Lyme and co-infection antigens. Anytime we have an LDI formula, the formula was originally sourced from a microbiology lab, and the microbiology lab essentially kills the microorganism with something called beam radiation, and we're left with essentially the intact body parts from the microorganism. So in other words, we're left with an antigenic formula. So the antigen formula is sourced from the microbiology lab, and then it undergoes serial dilutions to create different potencies of the formula in question. So when we're talking about the Lyme LDI formula, that's a combination of 4 different genuses, so Borrelia, Bartonella, Babesia, and Ehrlichia. And within the Lyme formula, I believe there's around 80 or 90 different species across those 4 genuses of different microorganisms. So it would be things like, Borrelia burgdorferi plus, say, 20 other species of Borrelia, and Babesia microdii plus, say, 15 other species of Babesia, etc. So it's a very comprehensive formula that will really likely, as clinical practice indicates, hits on a wide range of the different species of these microorganisms that might be causing symptoms for your patient. So the 20C refers to the degree to which that formula has been diluted. So C standing for 100 in Roman numerals. A 20C formula compared to that original stock formula of antigen from the microbiology lab has been diluted by a magnitude of 100 to the power of 20, so a 1 with 40 zeros behind it. So it's very, very dilute. And as we'll see, there are many different potencies that we can use. But in this case, the patient was started out with a Lyme 20C potency, so meaning she had 90, give or take 90 different antigens from these different genuses of Lyme and co-infections, and they were diluted down to quite a high extent, and that's what was in the formula that she was given. So she took that first dosage on January 30th of 2016, and for the next 2 days she felt a lot better, which was great. Then 10 days later, she took the same dosage again, so another Lyme 20C. As we'll discuss, LDI is dosed with a maximum frequency of once every 10 days. So she took that next dosage and she felt better for 7 days, which was great. So we're really happy. We found good doses right off the hop, and that was great. About 9 days later, she took another dosage of the Lyme 20C, and she felt a little bit better overall, but it wasn't nearly as good as the previous 2 dosages. On March 1st, she took the same dose again, and she felt no different whatsoever. So at that point, I knew that the dosage was no longer high enough. We worked with the dose the first 2 times, and it provoked a good change. Third dose was kind of a swing and a miss, and the fourth dose was just completely flat. So I knew that we had to increase the dosage, which is a very common thing that happens with LDI. So on March 11th, I recommended that she take the 20C formula again, but we drew up 6 units as opposed to only 4 units. The standard dose for an LDI formula is 4 units on an insulin syringe, so 0.04 milliliters. So by giving her 6 units, I was effectively increasing the dose by 50%, so she was getting a significantly stronger dose. So she took that dosage and she felt fantastic for 8 days. She was very happy because she was feeling better before, but she said this was an even better response than the previous, like the first two dosages, and it lasted even longer than the second one did. So from March 21st to the present, her symptoms have been virtually eradicated. The fatigue and the diffuse arthralgias and the Bell's palsy and the heart palpitations, everything is gone. The one thing that remained was unilateral knee and hip pain, which would improve with the subsequent dosing. She was still taking dosages every 10 days, but and her those specific joint pains would improve, but she found that it would feel better for maybe 3 or 4 days, and then the symptoms would relapse. So at that point, we started doing some ozone injections into those joints, and that was helping a lot as well. And I'm still treating the patient to date. However, those joints keep on getting better and better, and she's doing very, very well. So this is a great example of how low-dose immunotherapy can be used really as the driving force behind a case of chronic infection like Lyme or a co-infection. Someone looking at this case with more of a critical eye might say, well, you started her on all these herbs, you started her on this diet, you were doing all these other things as well. Maybe that's what was making her better. Maybe the LDI had nothing to do with it. And that would be a fair point to raise or a fair question to ask. But one of the really nice things with low-dose immunotherapy is that you can tell very quickly whether it's helping or not. The vast majority of patients will have a response to low-dose immunotherapy within about 48 hours of the time that they take the dosage, which really helps to tell us whether it's helping or not. Some patients don't have a response until about 5 days later, so there can be a delay, which is part of the reason why we leave a 10-day window between dosages rather. But in this case, we could say, sure, she started the herbs and everything on January 29th. She took LDI the next day. Maybe she was feeling better from the herbs. And, maybe for some reason there was this punctuated response. So she felt better for a couple of days on the herbs. Then another 8 days went by. She took her next dose of LDI. She just happened to feel better from the herbs again at that point. But it really wouldn't help to explain why she had no response to speak of for approximately a month between February 16th and March 11th, when she would have taken her March 11th dosage where she felt fantastic. And even to date, where her unilateral knee and hip pain feel better after she has another dosage, all these other things she's been on consistently the whole time. So it's really beyond a shadow of a doubt that the LDI is really what's making this particular change happen for her. The next case is looking at a patient where comprehensive antibiotic therapy combined with other comprehensive integrative therapies did not affect a change in a patient, and it was LDI that really made a difference in their case. So this is a good case study that demonstrates how LDI can be used in those treatment-resistant cases, or it could also be used in cases where the, say, antibiotic therapy or comprehensive antimicrobial therapy, whether it's from IVs or herbs or whatnot, seems to be helping, but it's not moving the patient along fast enough, and LDI can help in those cases. So this patient was a 60-year-old female at the time of initial presentation to my office. She had a working diagnosis of MS, and she was diagnosed with MS in the late 80s. And she presented with polyuria, dizziness, paresthesias, and fatigue. She'd been working with a really fantastic Lyme-literate medical doctor for the previous 12 months. She'd been taking lots of antibiotics, antiparasitics, and other pharmaceutical treatments. She was also working with antimicrobial herbs, vitamins, and minerals. And I asked her how she was feeling, and she said she wasn't really sure. She thought maybe she was a little bit better. So it was telling me that with 12 months of therapy, at the very least, she was tolerating it well, but clearly it wasn't making a really big change for her. So in November of 2015, she came to my office and we started the LDI therapy. So I started her with a Lyme 18C formula. So the first patient that I presented on, she received a Lyme 20C formula. So this patient also received the Lyme formula, so all the antigens from Borrelia, Bartonella, Babesia, and Ehrlichia were in there, the same ones, but this was at an 18C potency, so meaning that it was only diluted by a magnitude of 100 to the power of 18, or a 1 with 36 zeros behind it. So whereas the other formula was 100 to the power of 20, this 18C formula was 10,000 times stronger than the previous formula. So it was stronger. So she took that first dosage, and unlike the first patient who had a response to her first dose, this patient felt no different. So we waited 10 days, we increased the dose to a 17C, no difference. Waited 10 days, increased it to a 16C, no difference. And it was like that until, well, we'll see on the next slide what happened. But by January of 2016, she had built all the way up to Lyme 18C. So she'd gone up, she tried 8 different dosages by that point, and she has experienced no change whatsoever. And that can be the reality with low dose immunotherapy sometimes. In some cases, we have to wait a while before we find a good dosage. We can't try a different dose every other day. So there can be that it can be one drawback where there is a bit of a waiting game in some cases. As I'll discuss in an upcoming slide, there are ways to fast track things somewhat. So you can ramp up through dosages faster than what I just described, but we'll discuss that in an upcoming slide. So in January of 2016, later in that month, we bumped up the dose by 4 steps. We went from an 11C to a 7C, and with that dosage, the patient actually felt a bit better. Her bladder had better control, her stamina was better, and her balance was better. So it was exciting because she'd been plugging away at it for 2 months, and finally we found a dose that helped. So I recommended that she take the 7C again, and she said once again she felt a bit better. So at that point, I was thinking, a bit better is good, but I really want you to say I feel markedly better. So I knew that the dose had to be stronger, so I increased it to 6 units, so 50% stronger than the previous 2 dosages. And she took that, and once again, she felt a bit better. So it was telling me that the 7C, even at 6 units, it still wasn't strong enough. Increasing it by just a couple of units wasn't strong enough. So I made the executive decision to go up to the next step, which is a 6C dosage. So she took the 6C dose and she felt markedly better for 2 days afterwards. So it was much better improvement than the previous 3 dosages. So she felt markedly better for 2 days. I decided to increase the dosage just a little bit more anyways and went up to 6 units. And she felt markedly better for 4 days. So it was a good choice in hindsight to do that. Then the patient went away on vacation, so she took a few dosages of the Lyme 6C with 6 units, and she saw that every time she took the dose, she would feel a lot better for about 4 days afterwards. And in between the dosages, her symptoms would relapse, but they wouldn't relapse back to the original baseline. So in other words, she was getting better over the course of time in between LDI dosages. However, after she'd taken LDI dose, she really noticed a difference. So in April of 2016, she was up to a Lyme 6C at 8 units, and that was maintaining benefits, but we were waiting to see if higher dosages would produce additional benefits. Now she's up to a 5C, and that seems to be producing additional benefits. So she's still a case in progress, but doing markedly better. And within the span of really a couple of months, she was making drastically better changes than what she had been seeing with 12 months of really comprehensive integrative therapy. So it really goes to show that, well, first of all, that LDI can really help in certain challenging cases, but it also goes to show that perhaps there's something more to treating chronic infections than just trying to blast them with herbs or blast them with antibiotics and things like that. And we'll talk about why that might be the case in an upcoming slide. The third and final case is a case that looks at a quote-unquote recovered patient. So a recovered patient, by my definition, is a patient who you've successfully treated. You've got them to the point where they're, say, 80 to 90% better. They feel a night and day difference since they became sick in the first place, but they're still not quite back to their pre-sickness health. So meaning that maybe they find that unless they take the herbs or periodically get IVs or do other treatments that you've recommended for them, then their symptoms start to relapse. Or you find that they've improved and improved and improved, but then they hit a plateau. And a lot of patients are really happy to, get an 80 to 90% improvement. But in some of these cases, based on my own experience, you can get them to improve even further, which we'll see in this case. So this patient was a 51-year-old female when she first came to my office. In 2012, she developed some symptoms of tremors, fatigue, night sweats, dizziness, brain fog, and arthralgias. She came to see me in March of 2013 for the first time, and at that time I started treating her with some antimicrobial herbs in a tincture form, like similar to the first patient. I put her on some B vitamins, some adrenal support. We started out with doing some weekly IV peroxide treatments, which we gradually tapered off as she got better. We did pulsed electromagnetic field therapy, which really helped with some of the neurological symptoms, and we did methylation testing, and I put her on some methylation support as well. So over the span of about a year, she gradually got better, and she really got to the point where she was left with some lingering fatigue, about a 2 or a 3 out of 10 on a visual analog scale, and she had some paroxysmal tremoring, but otherwise she was doing a lot better. In September of 2015, she called my office and told my front desk, and they told me that she was suffering from chills and dizziness and fatigue and nausea, and the tremoring was getting worse. And at that point, she had really weaned down off of things. She was doing IVs maybe once every 6 weeks or so, maybe every 8 weeks. And she was on a lower dose of her herbal formula, maybe a quarter of a teaspoon twice a day instead of 5 mils BID. She was still taking some adrenal support, but really we backed off on a lot of things. So it sounded to me at the time that it sounded like her Lyme or chronic infection symptoms were relapsing. So I recommended that she do 2 weekly IV peroxide treatments. And sure enough, she felt a lot better. She wasn't quite back to her baseline, but she was definitely better with that. So it was really kind of clinically confirmed or strongly suggested that we were dealing with an infection relapse. So at that point, I felt like we were at a bit of a crossroads because we could have gone ahead and just treated her more comprehensively again for a while to get her back on track with some more IVs, some stronger dose herbs, etc. Or we could try the Low Dose Immunotherapy and see if that would help. And so I gave her the option, and she decided she wanted to try the Low Dose Immunotherapy. So on October 22nd of 2015, she took her first dose of LDI, which is a Lyme 25C. You'll note that that's quite a bit more dilute than the first patient who had a 20C. 25C is approximately 10 billion times weaker than the 20C. And I did that because I knew this patient was sensitive and I didn't want to risk flaring her up. So she took that dose, and fortunately we got lucky and she felt better with the first dose, which is great. So then dosed her about, 2 weeks later, and she took a 26C, which is an even weaker dose, and there was a reason behind that at the time, and she felt better with that too. Then she took a 26C again, there was no change, and so from December of 2015 to February of 2016, we were kind of going up and down with the dosages. The patient being fairly sensitive, we had to really fine-tune things, but most of the dosages made her feel better. Some of them did nothing. Some of them she felt like maybe she flared up a little bit. But by March of 2016, we found that going anywhere between Lyme 26C, 4 to 6 units, seemed to be the best for her, and she was just getting better and better with each dose. And just before I gave this presentation in April, she gave an update saying it was the best that she felt in years, which was great. It was great for a couple of reasons. One, because she was feeling better, which is the most important thing. But the other reason it's great is because we made the mutual decision to work with the LDI rather than getting her to jump back into doing a fairly comprehensive treatment protocol. And comprehensive treatment protocols are great, but they are time consuming. This patient lived about 5 or 6 hour drive away, so to come in for treatments was a really big effort for her, and expense and time consuming and whatnot. And comprehensive treatments are also expensive. Low dose immunotherapy, in contrast, is very inexpensive. And as such, if you can get away with using a treatment that's easier, less invasive, then using the low dose, using that treatment is a better option, in my opinion. So here's a brief history of low dose immunotherapy. In the 1960s, a medical doctor from the UK named Leonard McEwen developed a therapy he termed EPD, or enzyme potentiated desensitization. And he used this formula to treat people for sensitivities and allergies to foods, inhalants, chemicals, and also worked with some formulas for microorganisms, which I'll get to in a minute. So he was using this therapy with success. He performed a number of studies on the therapy, which I'll show in a subsequent slide, and so that was great. In 1990, a medical doctor named William Schrader from New Mexico went to the UK to be treated by Dr. McEwen for his own lifelong allergies, and Dr. McEwen cured him of his lifelong allergies. So Dr. Schrader was happy and impressed with that, so he brought the therapy back to the States. At some point, the FDA mandated that the therapy's name be changed, so Dr. Schrader coined the term low dose allergen therapy, or LDA for short. And effectively, these are the LDA formulas that we have. So once again, for foods, inhalants, chemicals, and then for Streptococcus, Proteus / Klebsiella, and Yersinia. Despite the fact that there have been 27 studies done on low-dose allergen therapy, once again, this is low-dose allergen therapy, which is a precursor to low-dose immunotherapy, which is what we're talking about today. There have not been any studies done that has specifically indicated how the therapy works, that to my understanding. The proposed mechanism of action is that the therapy is working due to the induction of T regulator cells that are specific for the antigen in question in the formula that's being used. As can be seen from this schematic of T regulator cells help to reduce pro-inflammatory cytokines, they help to reduce a Th1 response and a Th2 response. And so that can be very important when we're dealing with a pro-inflammatory condition. It's reasonable to assume that there would be a T regulator component to why low-dose allergen therapy works, because when there are issues with allergies to, say, inhalants or foods or chemicals, then generally that's considered to be a Th2 response. So the fact that those conditions can get better using low-dose allergen therapy would support the idea that there may be a Th2 regulating component to it. Similarly, the LDA formulas that are used or the LDA formula with Proteus and Klebsiella in it can be used with success to help treat rheumatoid arthritis and ankylosing spondylitis, respectively, because studies have been done linking those two microorganisms to the propagation of those autoimmune disorders. And where those types of pro-inflammatory autoimmune disorders would generally be considered to have a Th1 dominance, that would also support the idea that perhaps the LDA is inducing a T regulator cell response. The long and short of it is that to date, the mechanism of action is not defined, but this is a proposed mechanism of action. This is a partial list of the 27 references to studies that have been done on LDA, and all of them can be found on Dr. Schrader's website. Dr. Schrader's website has lots of information about low-dose allergen therapy, and I would highly recommend looking into training to use that therapy as well, because it can be very useful and effective. So flash forward to 2008, a medical doctor by the name of Ty Vinson, who practices in Alaska and Hawaii, coined the term low dose immunotherapy. And Dr. Vinson had been using low dose allergen therapy with success for some time, and he started working with LDI formulas to treat different chronic cases that weren't responding to other treatment. My understanding is he started out with treating Lyme and yeast syndromes using LDI and saw good results. He used it in his own practice for about 5 years before he started teaching it to other doctors, and he's really expanded the treatment since then, which I'll get into in some subsequent slides. But low-dose immunotherapy is the brainchild of Dr. Vinson. So the proposed mechanism of action for how low-dose immunotherapy is helping in a condition like chronic Lyme disease or co-infections, once again, it's not defined. There haven't been any studies done on low-dose immunotherapy itself, to the best of my knowledge. But given that it's so closely related to low-dose allergen therapy, it's really just an extension of it, then we can make some assumptions that there might be a similar mechanism of action underlying LDI as well. One possible explanation for why low-dose immunotherapy can help in cases of chronic infection is that there may be a molecular mimicry issue. This is a diagram of how infection with Campylobacter jejuni can sometimes precipitate Guillain-Barré syndrome. So if the um, red triangular antigens on the C. jejuni bacteria happen to look like the red triangular antigens on the Schwann cell, then you wind up with this, neurological issue. So in a similar sense, perhaps if the Borrelia are expressing antigens that happen to look like a myocyte or happen to look like certain neurons, then that might create this sort of molecular mimicry where the body's essentially attacking itself in an autoimmune-like fashion. So by bringing the LDI into the mix, you're going to lead to this. Well, the putative mechanism would be that there'd be a T regulator response that would downregulate the production of those autoantibodies and then lead to symptom improvement. With LDI, we know clinically that it leads to symptom improvement. Just why does it work? We'd have to speculate at this point until some studies are done. Another possibility is that perhaps the body has just essentially become hypersensitive to this infection that's living inside of it. Just as everyone has strep growing inside of their throats, but not everybody develops strep throat all the time. It's really when there's an overgrowth or an overexpression, or in a similar way, how we carry people who are infected with the herpes virus can carry it for years without having an outbreak, but under the right conditions, then they'll have a lesion that appears. Perhaps in a similar way, people can be carriers for chronic infections like Lyme, and it's only when their immune systems become depleted that they start expressing symptoms. And then the bacteria or parasites, in the case of Babesia, can grow and multiply and then create an overgrowth, which is why something like antimicrobial therapy can help in a lot of cases. But the question would be, why doesn't the antimicrobial therapy fully eradicate it in certain cases? And in my experience, most cases don't have a full eradication of symptoms just using antimicrobial therapy alone. It isn't until we start healing the immune system and boosting up nutrient levels in patients or bringing low-dose immunotherapy into the mix where we can see these essentially full recoveries for patients, or as close to a full recovery as can be expected. So perhaps if there's this sensitivity or intolerance that has been developed to the microorganisms, then that's why the LDI seems to be helping. But in any event, it seems to be this immunomodulatory effect that's really important. Like was demonstrated in case number 2, the patient with MS who'd been on wonderful comprehensive therapies, but it wasn't until we brought in the low-dose immunotherapy that she started noticing significant improvements. So this can be a very, very important thing for patients, and indeed that's what I've been seeing in my practice. I've already mentioned the lion's share of what's involved with the LDI composition. The one thing I haven't yet mentioned is that one of the ingredients that goes into the LDI formula, in addition to the antigen mixture, is the enzyme beta-glucuronidase, which of course is involved in deconjugation reactions in the intestinal tract from bacteria that produce it. Beta-glucuronidase evidently acts as a lymphokine agent, which is it's believed that that's why there's this possible T regulator cell production that occurs when you're administering the low-dose allergen therapy, and by extension we can assume that's what's happening with the low-dose immunotherapy. With LDI administration, there are 2 routes of administration that are possible, intradermal injection or sublingual drops. Both of them have equal efficacy in practice. Dr. Vinson has found that in his own practice, having administered thousands and thousands of treatments, and it's something that I've absolutely confirmed in my own practice too. Being a practitioner who uses a lot of injections, I was skeptical initially that the injections, I figured they would work better, and we started out just doing injections, but very quickly when you have patients who live hours away or patients who don't want to come in every 10 days for another treatment, you start using sublingual drops very quickly. So they're drawn up in and I found the drops worked just as well. The syringes, or rather the solutions, are drawn up in insulin syringes either way. So the patient's just either sent home with the drops or they're mailed to the patient and they squirt it under their tongue, hold it for 30 seconds and swallow it, and that's all there is to it. So very user-friendly for anyone, including pediatric patients, which can be very useful in those patient populations as well. The next step after deciding on a route of administration is to find the right dose. So if the patient receives a dose that is too low, they're going to feel no different, which would be the neutral face on the left-hand side of the slide. If we find a dose that hits or rather, if we find a dose that's exactly perfect, so we've hit the nail right on the head, the patient is happy, which will be the center face. And if the dosage is too high, the patient will actually experience a flare of symptoms, and then they will feel unwell, so that is represented by the sad face. With low dose immunotherapy, the idea behind it is that we're exposing the body to a certain amount of antigen in the formula that's given. And assuming that we're on the right track with believing that there's a significant immunomodulating effect that's happening with low dose immunotherapy, because there's an underlying hypersensitivity reaction to the microorganisms in question, it stands to reason that if we give an antigenic load in this formula that's too high, then the patient's going to feel worse because we're essentially dumping fuel on the fire. We're adding more antigen into the mix. The antibodies that are just waiting to pounce on the microorganisms in question will see the body parts and say, hey, let's pounce on that instead. And you'll see a pro-inflammatory reaction that'll exacerbate things like fatigue and pain and headaches and neurological symptoms or whatever it is that the patient's suffering from. So if the dose is too high, the patient feels worse. If the dose is too low, the patient feels no different because the antigenic load was definitely too low to provoke a negative response, but also too low to produce a valuable therapeutic response that the body can really sink its teeth into and possibly produce T regulator cells towards, if that indeed is what's happening with LDI. We've already talked about the centesimal scale. So what is the best starting dose? Well, that really depends on the sensitivity of the patient. The average patient will usually be started around a 15C. A patient that's particularly sensitive would be maybe around a 20C, and then a very sensitive patient might be around a 25C. I've had patients where we had to go as low as a 50C, so there's always the possibility of making it more dilute. In my practice, I see a lot of patients who are very, very, very sensitive, where they react to virtually anything that they put in their bodies. And in those cases, we can start very low. Let's say we start at a 50C, and if they react to a 50C, then we can dilute it down to a 100C if we have to. We can always make the formulas more dilute. So this therapy really lends itself well to patients who are quite frankly too sensitive to take or try other treatments. We can always go lower. So after the dosage has been decided upon and it's administered, then after 10 days, we have to see what was the response to the treatment. Was the patient better? Were they worse? Was there no difference? Or maybe the patient wasn't sure. If the patient feels better, they get a booster dose to try to keep the improvement rolling. If the patient feels worse, we have to lower the dose down, typically by a lot, just to try to then undershoot the optimal dose because we don't want to create two flares in a row. If the patient feels no different, I'd recommend taking a higher dose. And if the patient's not sure, then if they're not sure how they felt, then it just really depends, and you have to use your clinical judgment at that point, which you'll rapidly develop if you start using low dose immunotherapy in practice. It's something that you'll get good at with enough practice. Once the optimal dosage is found, in other words, the dose that is giving a good response, then that dosage is administered once every 7 weeks, and then booster dosages can be given in between every 10 days. I'm going to take a quick moment to speak about the protocol for using low dose immunotherapy. In Dr. Vinson's training materials, which we'll get to in just a couple of slides, he very succinctly goes over the protocol that he's developed for using low dose immunotherapy. And I would highly, highly recommend that you follow Dr. Vinson's directions to the letter when using low dose immunotherapy. He's been fine-tuning this therapy for over 8 years now, and he's really tried a lot of different permutations and how it can be administered, and I would really highly recommend following his directions to the letter. The reason that I'm taking the time to mention this is that it seems that there are some practitioners out there who have done the training and learning to use low dose immunotherapy, but unfortunately they're using it wrong and they're making people feel really sick on this therapy. And as such, LDI is in some cases getting a bit of a bad reputation as being something that can really flare people up. I've had a couple of patients come to my own practice who have been leery about trying the LDI because they read on message boards online that people started taking it and they felt really sick. And it turns out what's happening in these cases is that the doctors who are administering it, they're saying, you know what, this is just like taking high dose antibiotics, or this is just like taking any kind of anti-infectious treatment. You have, it's no pain, no gain. You have to feel worse before you feel better. You're just herxing, etc. And that is absolutely wrong. Hopefully, everyone watching this presentation will be able to already pick up that, yeah, you wouldn't do that. If you feel worse, you go to a lower dosage, because if you feel worse, it means that you've added more antigen into the mix than the body can handle, and you need to drop it down. So there seems to be some misunderstanding with some people who are using this therapy in practice where they're essentially administering it incorrectly, and it really shouldn't be used in that way because it won't work and people are just going to feel terrible on the therapy. So if you do start using low-dose immunotherapy, please make sure that you're using Dr. Vinson's protocol, because that is the absolute best way to do it. Low-dose immunotherapy can be combined with other treatments. It seems to play nicely with virtually everything else. I've had patients on very comprehensive naturopathic protocols, patients coming in on every pharmaceutical drug under the sun being treated for different conditions, and LDI has not led to any negative interactions with any of those medications. One exception might be immunosuppressants, because they would likely interfere with if there is indeed a T regulator cell component to LDI, it would likely interfere with that process. I've had a couple of patients who are on immunosuppressants and they still respond to the LDI, but my presumption is that they'd probably respond faster and better if they weren't on the immunosuppressant. And if they came off the immunosuppressant, then we'd probably have to adjust their LDI dosage. I assume that we'd likely need a weaker dose because the immunosuppressant would be necessitating a stronger dose to get the same T regulator cell response that we are looking for. Of course, immunosuppressants are sometimes of vital importance, so of course you wouldn't recommend stopping an immunosuppressant unless it was clinically safe to do so, but it's just something to be aware of. Another thing that's important is to make sure that any variables are minimized around the time that the LDI is dosed, because you need to know, does the patient feel better, do they feel worse, or do they feel no different? So I would never start a patient on another brand new therapy at the exact same time as LDI unless I was very confident that that therapy was not going to provoke a major change for them right off the hop. So the first patient that I presented on today, she started her herbs and everything the day before she took her first LDI dose. What I do and I just made that judgment call in that particular case, what I do with most patients is say, take your LDI dosage first and then wait a few days to see if there's any response, because if there's going to be a change, it's likely going to happen in the first 48 hours, and then start your other supplements. Or when we're using IV therapy, we'll usually get into a rhythm where the patient will be coming in for a weekly IV treatment, and then they'll wind up doing their LDI dosages about 3 days after each IV, just to make sure that there's no delayed response from the IV that we would potentially falsely attribute to the LDI, whether it was a benefit or a flare-up reaction. And sometimes doing that will interfere with the dosing every 10 days, but dosages can always be spread out further than every 10 days. They just shouldn't be given closer than 10 days apart. A very brief note on low-dose immunotherapy as a diagnostic tool. One reason that I really like low-dose immunotherapy is that I feel it helps to confirm whether I'm on the right track in chasing down a given type of microorganism. An example of this in practice is I was treating a patient with fibromyalgia, and she was one of my recovered patients. She felt 100 times better than when she first came in. But she still needed some Myers cocktails with ATP every couple of weeks to keep her feeling as good as possible. Otherwise, she'd start to dip in terms of her energy. So in conjunction with doing these treatments, I said, well, you're a lot better, but still not 100%. Why not try some low dose immunotherapy? So we ran through a few dosages of the Lyme LDI, and we gave her a 15C Lyme LDI. Then I gave her a 9C Lyme LDI, it's kind of part of my fast tracking protocol. And then I gave her a 4C, which is the maximum dose. She had no response to any of those formulas. So I said, oh, that's surprising to me because I really suspected Lyme, or at least, Babesia or Bartonella or Ehrlichia, and you didn't respond to any of them. So I then gave her the yeast LDI in a similar type of dosing pattern, and no response to that either. So then I tried the Mycoplasma formula, and sure enough, we found a dose of Mycoplasma where she felt fantastic. She had a day and a half where she felt markedly better. And so that was really exciting, and we've been working with the LDI since then. But the the Mycoplasma was really the dose that she responded to. So the only conclusion that can be drawn in a case like that is she did not seem to have a hypersensitivity reaction to Lyme or one of the main co-infections, nor did she have a hypersensitivity reaction to yeast, but we can fairly safely conclude that she does have a hypersensitivity reaction to Mycoplasma in her body. So it's something that can be quite useful, especially in cases where patients are not responding to treatment, and then say you feel that they have Lyme disease, but you give them the formula and they don't have any type of a response, and then you could run through other co-infections like anaplasma or mycoplasma or HHV6 or whatever it happens to be. But if the patient's still not responding to that, then you can really just say, you know what, let's throw random things into the mix. Let's throw in, herpes simplex virus, even though you've never had a cold sore in your life, or let's throw in varicella zoster virus, because who hasn't had chickenpox or a chickenpox vaccine? Or let's throw in the parasite mix, even though you have no history of anything suggesting you might have a parasitic infection. And we can do combination formulas where, for all intents and purposes, we're looking to see, do you feel better or do you feel worse from any of these combination formulas? And I've had a couple of patients to date now where we work through everything that made sense for them in terms of Lyme and yeast and whatnot. And it wasn't until I threw in sort of the majority of the formulas we had into one super dose where the patient said, wow, I feel better. My Bell's palsy drastically improved and my hot flashes are gone now and my headaches are so much better. And that made a really big difference in that particular patient case. So, and then that helped to show me that, well, yes, there is a hypersensitivity reaction going on here, but it wasn't to the things that I was chasing down in the first place. As I've already alluded to, there are a number of non-Lyme LDI applications as well. This is a partial list of all the formulas that are available. In my practice, the second most common formula to use after the Lyme formula is the yeast formula. That would be followed by Mycoplasma. That would be followed by probably a tie for the Crohn's mix and Streptococcus. So I've seen really fantastic clinical responses to all of those formulas. Same with the skin flora mix for acne. So LDI it's so versatile. It's a wonderful therapy, and Dr. Vincent is constantly experimenting with new formulas and making them available. And it's really exciting therapy. It can work very well for many patient cases based on my experience. Learning to use LDI in practice. So learning to use LDI in practice is thankfully very easy. It can be very easily learned from the comfort of your own home. You don't have to go to an in-person course and incur expense for traveling, etc. The first thing you need to do is contact Dr. Vincent's office, and his website is here, and you would purchase the LDI training manual from his office. When you, in the manual, it's probably about 40 or 50 pages. It's a very easy read. Dr. Vincent is a very engaging, entertaining writer, so I got through it all in a night, no problem when I first purchased the manual. He's always updating his manual every year and putting in new clinical pearls and observations and modifications to his method, so it's a really valuable investment to make. When you purchase the manual from Dr. Vincent, His office will then send you the LDI antigens at no charge except for the cost of shipping to your clinic. So it's um, that's how you access the antigenic formulas. In his manual, he also explains how you could make the formulas yourself if you were so inclined. Um, but it would be drastically more cost efficient to get them from Dr. Vincent himself. After reading through the manual, I would also highly recommend viewing the past webinar recordings that Dr. Vincent has made on LDI. Starting in August of, I believe it was August of 2015, he started doing monthly webinars through progressivemedicaleducation.com, and I attended all of them, and every single one of them was well worth the time and effort to attend. They're about 2 hours long. You can purchase the past recordings. They're not very expensive at all, and he just drops lots and lots of clinical pearls. It's a great opportunity to ask questions for clarification. He'll go over cases if people submit them to him. So he'll be resuming those in September of 2016, and it's something I would highly recommend pursuing if you're going to start using LDI in your own practice. Unrelated to LDI, well, related to LDI, but not to what we talked about today, doing training in LDA therapy is also a good idea, in my opinion. That can be done via the American Academy of Environmental Medicine. That can all be learned from the comfort of your own home as well through their training manual and videos. And as I said, participating in future webinars is a good idea, and also trying to find an LDI buddy is a good idea too. There is an LDI Facebook group for people who have done training in the therapy, and Dr. Vincent's webinars are a good medium as well to touch base and kind of bounce ideas off of other people. My clinic website and contact information is listed here. I hope that this presentation was valuable and informative. I hope that if you are a clinician watching this, that you are excited about the possibilities that LDI can hold. And I thank you for your attention.